All right, thank you so much. So my name is Jay, and I'm actually not Dr. Jay Lusk yet. I'm a fourth year MD MBA student at Duke University, and I'm glad to have this opportunity to talk to y'all a little bit today about the work that we're doing that we think we're optimistic is a future path to improving outcomes for patients with ICH, and that involves identifying biomarkers at the tissue level for patients with hemorrhagic stroke. So for disclosures, you can see my disclosures on this slide. We're very thankful as well to Nico, who provided the primary funding for this study, and to the Grifols-Lucas Foundation, who provided funding for our normative data. So for some basic background, ICH outcomes, as we all know, continue to lag behind the improvement that we've seen in outcomes for ischemic stroke over the past several decades. And we've continued to see disappointing results from phase 3 trials of a variety of ICH therapeutics listed on this slide. And part of the reason why we suspect that may be the case is because there may be a multitude of different mechanisms that influence outcomes for ICH. First and foremost, as relevant to this talk, being neuroinflammation as a driver of secondary tissue injury. And primarily, our hypothesis that has been well played out in preclinical models is that pro-inflammatory cytokines stimulate the activation of neutrophils, lead to widespread activation of inflammatory pathways within the brain, and lead to edema and reactive injury that causes subsequent secondary damage to the brain tissue. And we also suspect from preclinical models that a delayed involvement of T and B cells may be involved and may contribute to some patients having delayed worsening of outcomes who initially appear to have a better trajectory. But we're left with a key problem, which is we're not sure how these preclinical findings, which are primarily done in rodent models, translate to human ICH, and how we could actually meaningfully understand these pathways and intervene upon them in human patients. And so the solution that we put forward for this is to actually take ex vivo samples of these inflammatory cell populations during routine clinical care, in this case through minimally invasive hematoma evacuation. So our study design that I'm going to talk about today was as a pilot and feasibility study where we coupled minimally invasive hematoma evacuation with a preservation system and flow cytometry to characterize neuroinflammation for patients with primary ICH. And we enrolled patients with supratentorial ICH within 24 hours of ICH onset and studied 7 patients from May 2018 to April 2019, all of whom had their hematomas evacuated within 12 hours of onset using the same surgical device. So for just some schematics to show what we're talking about here, we've got our, in panel A here, the actual console, which is connected to this automated preservation system, which allows for the evacuated material to be immediately put on ice and therefore shared and therefore preserved to prevent injury from thermal sources. There's a small filter here to essentially prevent debris from moving into the filter, and the preservation system can actually be sealed off for transport, as you can see in panel C here. And once that it's sealed off, you're able then to just directly transport this on ice. And so what we did here is we basically rapidly chill this harvested tissue. We keep it contained and chilled during transport. And what we did for this pilot study was we evacuated the hematomas at Duke Raleigh Hospital, which is around 30 miles away from Duke University Hospital, and then transported them to Duke University Hospital, where they underwent further processing and were frozen at minus 80 degrees Celsius until they were ready for flow cytometry, which was then done in a batch processing method. The flow cytometry is honestly not my area of expertise, and you can find details about this in the paper that we recently published in World Neurosurgery that I've linked here, and I'm glad to provide that paper. Actually, I think it's open access, so folks can read that if they're interested in those procedures and contact some of our flow cytometry experts that work with us. But in essence, we use standard flow cytometry procedures that had previously been validated in other human models. So for some basic results here, we had a total of 7 patients again, median age of 58, most of whom's ICH etiology was due to uncontrolled hypertension. None of these patients had active infection or history of immunological conditions, and there were no adverse safety events associated with the use of our hematoma evacuation system. So here's what the flow cytometry results look like. And the basic idea here is we're comparing evacuated hematomas to a reference population of peripheral blood mononuclear cells. So essentially to a theoretically comparable population, however, in the periphery from healthy controls. And the first thing that we notice here is that even in a very small sample size, we see that patients with ICH have substantially higher numbers of natural killer cells and monocytes compared to the peripheral blood of healthy controls. And this is consistent with some of the preclinical evidence on mechanisms of neuroinflammation in ICH. And we did collect a great degree of much more specific data about specific cell subtypes that fills literally dozens of pages of information, which we also have made available for folks who are interested in that preliminary data. But for basic feasibility, this showed us that we can see results even in a very limited population that tell us what we probably suspected to be true but hadn't entirely known, which is that patients with ICH have different inflammatory profiles than healthy patients who are not having ICH. There's some fairly obvious limitations. This is a single center case series, a very preliminary analysis. We couldn't adjust for any confounding factor and did not attempt to do so. And of course, a comparison to peripheral blood from healthy controls is a poor substitute for a matched comparison for actual blood that is obtained directly from the brain, which we're obviously never going to get. However, we think that this is a good foundation upon which future research can be built to allow us to better understand what really is going on with the neuroinflammatory axis after patients experience ICH. And most importantly, this can help us learn how we can potentially modulate those neuroinflammatory processes to help identify and catalyze new insights into treatment methodologies that can advance outcomes for this patient population. And so again, here we think that this has the potential to unlock some really fascinating mechanistic insight about ICH and to catalyze the generation of future therapeutics as we also begin to expand potentially the role of minimally invasive hematoma evacuation in the care of patients with ICH. And we're planning on moving forward with a multi-institutional study to expand some of these findings and begin to replicate this in larger volumes of patients in a way that's more powered to really test some of these mechanistic hypotheses that come to us from the preclinical literature. Now, I'd just like to give some acknowledgements. Our flow cytometry team, Janet Stats, Kent Weinhold, and Quentin Quinones, our neurosurgery colleagues, Peter Grossi and Shai Nimji, and then our neurocritical care colleagues, Danny Laskowitz and Luke James, who is the PI on this research. And if you're interested in discussing this research more with us, you have questions or interested in getting involved in future work, please feel free to reach out to both of us. And also please feel free to follow me on Twitter, although I can't guarantee any insights about anything, particularly neuroinflammation. And again, appreciate the opportunity to share some of our research today and look forward to seeing what kind of work will come from our deepening understanding of tissue level neuroinflammation of ICH in the future, and would be glad to take any questions.
Thank you, Dr. Lusk. Any questions? How did you get interested in this at your level, and where do you see it all going for your career?
Yeah, absolutely. So I, as much as I hate to say it at this meeting, I aspire to become a vascular neurologist, not a neurosurgeon, but I initially became interested in this research because when I was caring for patients in my clinical rotations as a second-year medical student in the neuro ICU, recognized that patients with ICH had really limited therapeutic options compared to their counterparts with ischemic stroke. And I was really interested in developing a better understanding of how we can really change that paradigm, and had the chance to get connected with doctors James and Laskowitz, who've been doing this kind of work for several years, and to have an opportunity to learn a little bit more about how this neuroinflammatory ecosystem works and to get involved in some of this pioneering research. I hope to continue to do this kind of research in my career. I'm an aspiring clinician scientist, and I do believe that the future of ICH research lies in translational science and in allowing for us to effectively leverage the fantastic science that's been done over decades in preclinical models and figure out how we can translate those insights to actually generate meaningful therapeutics that we can offer to patients with ICH, and hopefully make this very deadly pathology and very morbid pathology, one that is much more survivable and leads to better outcomes on the population level.
Well, congratulations on your clarity and your mission and determination to accomplish that. So it's very admirable. And look, anything we see now, whether it's the pharmaceutical industry or others, are looking for biomarkers. So biomarkers in what we do in neurosurgery has not been front and center, but the time perhaps has come. So keep up the great work and thank you for your contribution. Anybody else have any comments or questions? Okay, thank you, Dr. Lusk. Appreciate it.